Good afternoon, everyone. Thank you for coming to my presentation. My presentation is about hydrorelease as a new injection technique targeting fascia. The technique we have developed is evolving every day. So let's begin. Hydrorelease HR is an injection therapy using physiological saline or other solutions that target various types of fascia. Combining this technique with rehabilitation can lead to significant results. Here are some specific examples.痛かった言ってね。
これ抵抗感あります。
ああ、
外線も見ます。
そういう方ね。
外線いきます。大丈夫です。で、ちょっと後ろ回してもらっていいですか。肘曲げましょう。これいかないですね。はい。
はい、じゃあ注射始めますね。
わかります。
はい、じゃあやりますよ。大丈夫ですか？はい。動いた。
緊張が入ってますか？ああ、いいですね。
今動いた。
はい。
もうちょっと。動いた。大丈夫ですか？CST やるやん。はい、曲も。はい、やります。
変わります。
変わった。
はい。
そういうとこでも変わる。
はい。
はい、やる。
あ、今来ました。
変わった。
はい。
あ、動いた。
今すごい。
動いた。いいじゃん。
今すごい。はい。
ここで一回さ、上げてもらって。軽い。
はい。
はい。あ、だ、なんか、
肘曲げてもらって。外に開いてます。お。違うか。後ろどうでしょうか。肘曲がります。
じゃあ、もうちょっと良くしましょう。
いいですよ。
大円筋、小円筋、肩甲下筋、前鋸筋。全部リリース。ね、前レール。
そうですね。
そうだね。そうで動いちゃうかもしれない。はい、やります。
もう、変わりますね。
ここにさっき広背筋はなかった。広背筋と楕円筋のあるよね。
もう、すごい動いてる。
動いてる。
もう、すごい。
売上げで半年分か。まだ我慢できます？はい。もうちょい。じゃあ、下のカプセル。うん。
新入人。
この表層もあるね。
はい。
これなんだこれ、広背筋か。
広背筋、大円筋。
大円筋か。
はい。
うん。
はい。
いいじゃん。じゃあもう一回しようか。いいじゃん。
だいぶまっすぐ上がるようになりまして、位置曲げ。外に開き。5度ぐらい上がってる。後ろはどうでしょう。肘曲がりますか？はい、ありがとうございます。
次回後ろのかもしれない。
あ、そうです。
はい。はい、おしまいで。History of injections with physiological saline. In 1980, Lancet physiological saline solution is reported as being more effective than mepivacaine for muscle pain. In 2016, we reported that physiological saline solution was more effective than mepivacaine for myofascial pain syndrome. Bicarbonate ringer solution is equally as effective as physiologic saline solution and less painful upon injection. So it's the best solution for now. History of injection technique in Japan. In 2010, I created interfascial block with local anesthetic to MPS. Then in 2012, the interfascial injection with physiological saline. In 2014, the ultrasound-guided myofascial release. I then created the ultrasound-guided fascial release. Finally, in 2017, we named US-guided fascia hydrorelease as an injection. As you already know, this is the criteria for MPS. We must treat these points and not the referred pain location. The trigger point appear not only in muscle and myofascia, but also in skin, tendons, periosteum, ligaments, and so on. As you know, this is fascia. I feel that MPS is an old concept, so I want to present a new one. Fascial pain syndrome, FPS. Fascia hydrorelease is also effective for FPS. We want to introduce fascial pain syndrome as a new concept rather than just myofascial pain syndrome. FPS is the sensory, motor, and autonomic symptoms caused by abnormal fascia. The specific fascia and fascial group that causes the symptoms should be identified. So today I'm going to explain my ultrasound-guided fascia hydrorelease technique. I will explain the definition. Fascia hydrorelease is defined as an injection technique for the release, separation, and relaxation of abnormal fascia to improve the extensibility and sliding in addition to having analgesic effects. We wondered why fascia release was so effective. As you know, it's because there is an abundant amount of sensory nerve endings in the outer layer of the myofascia. What is fascia? The definition of fascia is under international debate. The reasons for the confusion about the definition of fascia might be due to a different understanding of various aspects of anatomical structures. Our proposed definition is microscopic anatomical structures forming of fibrous with the function of fascial network system. Japanese Non-Surgical Orthopedics Society, JNOS, is conscious of smooth discussion by dividing expressions for fibrous structures into systems, macroanatomy and microanatomy. We had deep discussion in Japan over the last few years with laparoscopic surgeons about fascia. What is the difference between hydrorelease HR and hydrodissection HD? First, the target of HR are fascia itself, but the target of HD are around the peripheral nerves, especially in the case of entrapment neuropathy. Second, the dosage is very different. The dosage for HD is much higher. HD aims to turn the image into a so-called donut or halo. HR aims to release the stacking fascia on US image as a so-called millefeuille sign or cake layer sign. This article also clearly describes the difference between the two procedures. The important thing is that US guided fascia hydrorelease USFHR targets fascia. Structure targets for fascia release are myofascia, retinaculum, ligament, tendon, tendon sheath, joint capsule, fat pad, fascia around the nerve, fascia near vessel, and ligamentum flavum. In particular, we have recently focused on perivascular fascia and the ligamentum flavum. I will show you some of these points. First, myofascia. This is being applied to shoulder stiffness. This is our article in Pain Medicine magazine. We injected only 1 ml pericardial ink between the trapezius and rhomboid, but it spread very widely. This is retinaculum release. This is being applied to Kelban disease. This video shows coracohumeral ligament CHL hydrorelease. This technique is being applied to frozen shoulder. This is an example of external rotation before treatment. After treatment, the range of motion has greatly increased. This is the effect of fascial hydrorelease on CHL in our article. Our data shows that all range of motion has increased and greatly increased after rehabilitation. This is tendon sheath release. This is being applied to trigger or snapping finger. Next, this is articular capsule of glenohumeral joint. This is being applied to frozen shoulder. And this is infrapatellar fat pad. This is applied to pain in the front of the knee joint, pain during weight bearing, etc. This video shows hydrorelease of fascia around the CH nerve root. It is being applied to radiculargia. Next, I will talk in detail about perivascular release. The figure shows effective treatment point for it. In the case of frozen shoulder, as shown in the first video, if the pain is strong, these blood vessels are released first. Performing release around the anterior circumflex femoral artery. Next is the case of plantar aponeurosis. After performing vascular release, the thickening of plantar aponeurosis improved. The injection target is the fascia around the posterior tibial artery. Release the tarsal tunnel and any part of the stacking fascia above and below it. This is tarsal tunnel release. Furthermore, search for stacking fascia around the posterior tibial artery. This is fascia hydrorelease around the posterior tibial artery. You will see an increase in pulsation after release. Presumptive action mechanism of HR or fascia are rehydration matrix, washing effect of pain substances, improvement of extensibility of fascia and sliding between fascia, improvement abnormal blood flow. Hydrorelease of fascia near vessel. The mechanism of action are the direct effect of fascia release and the indirect effect of improved blood flow. This article explains about prolotherapy. Prolotherapy is an injection method successfully used in the degenerated and damaged joint structures, including tendon, cartilage, and other connective tissues. Prolotherapy is superior to exercises. Prolotherapy could provide significant improvement for clinical outcomes in developmental dysplasia of the hip and might delay surgery. We suggest that the idea of classifying local treatments is to determine whether they aim to loosen or tighten the tissue and fascia. As you know, image findings often do not correlate with pain. This patient visited my clinic complaining of hip joint pain. Since he does not want surgery, I preferred prolotherapy and perivascular release. Releasing this point increases blood flow to the hip joint at the head. The combination of prolotherapy and perivascular release is very useful. Stacking fascia can be seen around the blood vessel. The patient is now able to travel abroad. Lastly, this is the ligamentum flavum release. The ligamentum flavum is a source of pain and limited range of motion, but is rarely treated in clinics. You can see the drug spreading around the nerve root from the posterior ligamentum flavum, and you can see the epidural artery arcade starting to pulse. Increased pulsation of epidural artery arcade means improved spinal circulation. Furthermore, we confirmed that the spinal color Doppler response was enhanced after ligamentum flavum release. C01, C12 posterior adherent occipital membrane and ligamentum flavum release is effective for crown-dense syndrome because the drug solution spreads from around the nerve root to the front of the spinal canal. This procedure also serves as a treatment around the C1 and C2 nerve roots that make up the cervical plexus. In addition, the release of cervical ligamentum flavum may be effective for neck-down syndrome, for which there were no effective treatments until now. This article explains that lumbar ligamentum flavum hypertrophy is a clinical pathological phenomenon considered one of the causes of lumbar spinal stenosis, and that the ligamentum flavum LF forms an aspect of the posterior wall of the spinal canal, and hypertrophy of each part of the LF can directly compress the spinal canal and cauda equina. LF extends outward and merges with the intervertebral fascial joint capsule and forms aspect of the central part, posterior wall of the spinal canal, lateral recess, and intervertebral foramen. Junction point of LF and facet capsule is very effective treatment point. In addition, LF and L5 can often be confounded by ultrasound, so this release is very effective for radiculopathy. This is the release of LF around the L5 nerve root. Spinal stenosis, disc herniation, and facet joint disease are interrelated. The common cause is thickening and hardening of ligamentum flavum and facet joint capsule complex, and its release is very effective. This is a list of typical hydroreleases. We created many techniques. We reported ultrasound-guided dry needling for abnormal fascia, cured chronic mandibular numbness 6 years after orthodontic surgery. And we reported that dry needling for abnormal fascia was effective in both pain and range of motion. After dry needling, shoulder pain severity improved and A-ROM was increased. In Japan, the main 4 types of intervention fascial pain are injection, manipulation, dry needling, and surgery. Based on pathophysiologic condition and characteristics of interventions, we have proposed how to select and combine various therapeutic techniques such as physical therapy, dry needling, injection, and surgery. The diagnosis is a multi-professional collaboration. Referred pain and the source of pain do not often match, so we must find the source of pain. The pain source assessment are orthopedic examination, analyzing motion during pain, peripheral nerve distribution, referred pain patterns, dermatome, fasciatome, and angiosome. It's very difficult, so we must collaborate with physical therapists and acupuncturists. Fasciatome is a distribution of nerves along the deep fascia. It's very useful for the diagnosis of fascial pain syndrome. We also use angiosome. It's useful for when perivascular fascia is suspected as a source of pain. Therefore, multi-professional collaboration is extremely important. Thank you for listening to our presentation.